Good morning, all. Welcome. We are going to start a new topic. It's about very known or well-known condition called acute immunodeficiency syndrome or AIDS. So we all we are all uh, going through a pandemic situation, and it's a viral infection. Uh, Even it's a RNA virus, and it can spread one to one through the airborne droplets. That's why we're all wearing masks. All right. But years ago, maybe in 80s or 90s, people were very panic about a condition called AIDS because this was spreading across the world, and people who get infection gradually have some problem, and finally complete lack of complete immunity, and that eventually leads to multiple infections, various infections, and finally the person dies. And it will take time, usually sometimes years can take. So we have learned that this is due to a particular virus called HIV, or human immunovirus, because it mainly affect the immunity of the person. So today we're going to talk about this particular condition, AIDS, and of course you have learned some aspects about the condition in the previous year, and hope you remember this case. This case is actually a 25-year-old male with history of multiple sex partners is admitted with complaints of unexplained fever, progressive loss of weight, persistent diarrhea, and generalized lymphoadenopathy for the past 6 months. And these are the symptoms with a person admitted, with the symptoms with the person is admitted, and some catching words includes history of multiple sex partners. So there you have learned that uh, having unprotected sex, whether it is homosex or heterosexual sex, unprotected sex is the major reason for the infection, transmission of the infection from one person to other one. So this particular case of the male who revealed that he has a history of multiple sex partners. So we will think when you take the history, and if we reveal this one, we will definitely will think about HIV infection, and we may go for the HIV test. Now, how do you test it? How do you do the testing? Of course, everything we'll discuss in the coming classes. So usually ELISA is the primary test. It is an immuno-based test looking for the antigen, viral particles, viral proteins and viral particles. And this is a lot of chance for the false positive with the ELISA. So to confirm the infection, we may go for another test called Western blot. I hope all of you, this part has been discussed in biochemistry, like how this ELISA test is done and what is Western blot, what exactly you're looking in Western blot, etc. Fine. So of course the symptoms are also very important. Like sometimes the window period of the virus is long. Sometimes the person can be asymptomatic for months. Now, when the person starts showing symptoms, usually unexplained and continuous fever is a important symptoms. Then you can not an unexplainable loss of weight, because even though if you're eating well, the weight loss is remarkable. Diarrhea is also there. Lymphadenopathy is, of course, like it's a generalized lymphadenopathy is common with the viral infection, so that is evident in this case. And he reported that all this problem is persistently present for the last 6 months. So he came to the OPD with all these complaints. And of course, you can definitely suspect a case of HIV here, because the history says that the person has history of multiple sex partners. Okay, so this is the case. I just refresh your linker case over here. Now let's talk about the other aspects of HIV. Let's talk about like the most here the most probable diagnosis would be HIV infection. All right, so let's talk about HIV, how HIV infection takes place, and test, what are the tests available. Details of the virus and all those things will be discussed in microbiology. And of course, a basic structure of virus is essential to discuss about the targets of the antiviral means antiretroviral medications. And what I want to tell you, one point is that HIV is a retrovirus. Okay, HIV is a retrovirus, and others like are other viruses, polio viruses or chickenpox viruses, all are DNA viruses. All right. So this virus synthesize DNA from RNA by using a particular enzyme called what is that enzyme? Why it is called retrovirus? Reverse transcriptase enzyme. Reverse transcriptase enzyme. Okay. So that's the reason it is called retrovirus. Fine. So this is about the scenario. Okay. So let's see what are the newer medications available for the treatment of HIV. What are the existing regime, like any other viral infections or treatment of tuberculosis or leprosy. HIV is also addressed or treated with multiple drugs, mainly because of the emergence of resistance. Okay, so what are the combinations of drugs available? So these are the points we're going to discuss by this topic. Thank you.
So good morning all. Let's continue with the antiviral therapy. So earlier you have studied about the antiviral medications like oseltamivir or anti-herpes drugs and many other hepatitis B, flu, influenza virus, herpes zoster, herpes simplex virus. So antiviral medications have been discussed in detail. Now, so far all these viruses were DNA viruses, where the central dogma of the genome is DNA. Whereas another group of virus, it's the core central dogma is RNA. Basically, this RNA convert into RNA, reverse transcription process will undergo, RNA will undergo reverse transcription process, and which will form the DNA. And this DNA can transcribe and translate various proteins required. And this DNA can be integrated into the host genome and synthesize the various enzymes and the proteins. So this is what the basic concept. So it was the AIDS was the a condition, acute immunodeficiency syndrome. It's recognized in the United States in 1981. In 1983, human immunodeficiency virus or HIV was isolated from a patient with lymphadenopathy. So this is the evolution. What happened in 1985? The first diagnostic test, it was ELISA, enzyme-linked immunosorbent assay, was developed to detect the antigens of the virus. So this is a primary test. Still, it is considered as a primary test. Now, by definition, an HIV infected individual with a CD4. Why the CD4? Because CD4 is the target of the viral attack. So the CD4 count may drastically comes down, and that is a marker for the infection. So the T cell, CD4 T cell count of it is less than 200 per liter has AIDS by definition. Okay, regardless of the presence of symptoms or opportunistic infection. So whatever, whether it is symptomatic or asymptomatic, if the patient's CD4 T cell count is less than 200, it is considered. Now the severity of the AIDS can be measured in terms of CD4 count, then the symptom. Okay, and there are A1, B1 and C1. Then the CD4 count between 200 to 499 per microliter, that is also considered, I mean, like divided A2, B2, C2. Then A3, again, if it is less than 200, the severity is A3. So B lymphocytes count is B3, and it comes in the indicator. See, AIDS indicator condition is C3. So the antiretroviral. So this is regarding the transmission. It's transmitted primarily by sexual contacts, both heterosexual and homosexual. It is also transmitted by blood and blood products. That's another way, blood and blood products. And also by infected mothers to infants during intrapartum or perinatally or breast milk. And risk on healthcare workers is also need to be ruled out. So the possibility of needle prick and other blood contacts, it's all possible. So after 30 years of scrutiny, there is no evidence that HIV transmitted by casual contact or that virus can be spread by insects. It is not a vector-borne disease. It is not a vector-borne disease. Now, epidemiology, I don't want to discuss the details of epidemiology. In 2009, 33.3 million individuals were living with HIV infected according to the Joint United Nations program. And the number maybe increase 2020, but the incidence, the rate of spread has decreased due to the effective effort of various organizations, governments and NGOs, etc. So this is the global incidence marked. You can see various locations, the Asian countries, African countries. In fact, the spread is very high in sub-Saharan African countries. This was actually a video showing the viral attack. So unfortunately, we don't have the video is now not functional. Anyway, this is life cycle of the virus. Regarding the pathophysiology, it causes immunodeficiency. It's a hallmark or a profound infection. Resulting primarily from a progressive, quantitative and qualitative deficiency of the subset of T lymphocytes. So the T helper cells contain CD4. So this is the target of the virus. Apart from CD4, the co-receptors like CCR5, CXCR4 are also required for the infection. So this is not only attack the CD4, the other co-receptors like CCR5 and CXCR4 are also attacked. Now this graph shows the symptoms and the infection. Primary infection, the blue shaded dot shows the primary infection and the green shade shows the symptoms. So it is in the weeks, in few weeks, maybe up to 8 to 9 weeks, this can spread the viral particles throughout the body, especially seeding of lymphoid organs, and that can eventually leads to various symptoms after a stage of clinical latency, and constitutional symptoms including the various weight loss, fever, then oral candidiasis, etc., and which eventually increase serious infections, opportunistic infection, and if it is uncontrolled, it can lead to death. So this is the sequence in terms of the symptoms. So this is actually general and neurological symptoms in connection with excuse me, HIV syndrome, where you can see the fever, pharyngitis, lymphadenopathy, headache, arthralgia, lethargy, anorexia, nausea, and all are very common. Excuse me. Then neurologic, meningitis, encephalitis, neuropathy, myelopathy, etc. Now, regarding diagnosis, as I told you, the preliminary or the primary ELISA continued to be the primary test. The possibility of false positive and false negative results are very high. So we have a more sophisticated Western blot. Western blot generally, it can assess the viral DNA particles. So it is a confirmatory test. Laboratory monitoring is possible. Usually it can be done by CD4 count measures. Measuring the CD4 count, CD4 T cell count in the laboratory test generally accepted as the best indicator in the immediate state of immunologic competence of the patient. Patients with the CD4 T cell count less than 200 per liter are the high risk of disease from pneumocystis jirovecii, and we, by definition, a patient is said to have HIV infection or AIDS when the CD4 counts fall less than 200. And CD4 count fall less than 50 per liter, high risk of disease from CMV. Now let's come to the topic about the treatment. It is a rapidly developing area. Various researches are ongoing, and as I told you, this is an RNA virus where the RNA can be reverse, which can undergo reverse transcription process and produce a DNA. So the proofreading is minimum and the chances for errors is very high. It can various 4 or 5 different groups of regimes or the drugs are available which can be combined in different regime. And most of the drugs, the treatment is a lifelong, which is required to control the viral replication. And most important problem is the emergence of permanent drug resistance. The reason, especially this is a RNA virus, there is no proofreading. So the DNA keep changing the DNA pattern due to mutation. And what happens when the viral particle undergo various mutations, the drug may not be effective. So it causes drug resistance. That's a most important challenge faced by the HIV management. Failure of an antiretroviral regime is defined as a persistent increase in plasma HIV RNA concentration. This is another prognostic marker measuring the RNA concentration in the blood. So keep a persistent increase in the HIV RNA concentration with a previously undetectable virus despite the continued treatment. So you have been continuing the treatment, but it is unable to arrest the replication of the RNA, which is a clear sign or indication of the
drug resistance or the failure of drug resistance. So this is what I wanted to tell you about the general aspects about the HIV. Now let's talk about the classes of the drugs. I told you there are 4 or 5 different groups of drugs available. So the first developed group of antiretroviral classes are NRTIs, nucleoside or nucleotide reverse transcriptase inhibitors. The name itself self-explanatory because it is the analog of nucleoside or nucleotide which compete or which competitively bind to the reverse transcriptase enzyme and block the enzyme. So it's a nucleoside analog which compete with the nucleoside and inhibit the enzyme. Second group of drugs are NNRTIs, which stands for non-nucleoside reverse transcriptase inhibitors. And what is the difference between NRTIs and NNRTIs? As far as the NNRTIs are concerned, this is not structural analogs. In case of NRTIs are basically structural analogs like zidovudine, lamivudine, etc. But NNRTIs are not structural analogs, but it can bind to some areas of the enzyme. Which enzyme? Reverse transcriptase enzyme, and block the actions. And this is examples like enfuvirtide. Okay. Then protease inhibitors. Protease is an enzyme responsible for the final maturation of the viral coating. After transcription translation process takes place, the final maturation of the viral particles takes place with the help of enzyme protease. And protease can be inhibitors like nelfinavir, entecavir, lopinavir, etc. Then fusion inhibitors. Fusion is the process, the first step where the enzyme, the virus glycoprotein bind to the CD4 receptors and co-receptors, and that segment, that part of the viral attachment is called fusion. And we have drugs which can inhibit the fusion. Then chemokine receptor antagonists. I told you not just CD4 is involved in the binding. Some other core receptors like CCR5, CXCR5 is also involved. So we develop certain drugs which can inhibit this chemokine core receptors and block the entry of virus into the host cells. Finally, we have integrase inhibitors. Integrase is an enzyme essential to integrate the viral DNA to the host DNA. I'll show you the picture, then you will understand. So these are the different groups of drugs available so far. Now this is the evolution of the drugs from 1987 to 2007, and still this is a pretty old one. The newer graph is available, including the integrase inhibitors, then CCR5 and CXCR5 inhibitors. So the graph is incomplete. Now this is a particular schematic diagram which shows the different stages. I think the next is better explainable graph shows. Now this is you can see here the first step, fusion. Here I told you the viral particle, the virus attached to the CD4 count, CD4, viral glycoprotein attached to the CD4 and the other co-receptor, and this process takes place. This is a fusion which causes the fusion. After fusion, the viral DNA or RNA particles enter. So that step can be inhibited by fusion inhibitors and chemokine receptor antagonist. So here, this is the first one. The second thing, NRTS. So I told you, reverse transcription is a process where the DNA is formed from RNA. RNA is a central part, so single-stranded RNA. And from the single-stranded RNA, reverse transcriptors synthesize double-stranded DNA. And this process is called reverse transcription. And the enzyme responsible for this process is called reverse transcriptase enzyme. Now, basically NRTIs, nucleoside reverse transcriptase inhibitors, are the analogs of the nucleotides. You know that nucleotides are the integral part of DNA and RNA. So it has the
thymine or nitrogen bases with sugar. Okay, nitrogen bases, sugar and phosphate group. So that structures, the NRTAs are also having the same structure, and these compounds will compete with the this actual endogenous nucleoside for the active site of the reverse transcriptase. And what happen? NRTAs go and bind to the reverse transcriptase enzyme and block this. So the process of DNA synthesis will be inhibited. Okay. Now this is NRTA and NNRTase. Both will inhibit reverse transcriptase enzyme. Now I have already told you the difference between NNRTA and NRTA. NRTAs are the structural analogs of nucleoside, where NNRTA are not the structural analog, but it can block. And NRTAs are competitively inhibit the enzyme, where NNRTA not a competitive inhibitor. The next group is integrase inhibitors. As the name indicates, it can inhibit the integration of the viral DNA into the host. This is the host nucleus, and this is the host genome. Now what happened? This is the integration process where it can incorporate it into the host genome and undergo transcription translation process. So that can be inhibited by integrase inhibitors. Now we have protease inhibitor. I told you, once the integration takes place, it starts to synthesize the viral particles, including the proteins like GAG, POL and all. And these proteins are essential for the assembling and final maturation. That process can be inhibited by protease inhibitors. So these are the 1, 2, 3, 4, 5, 6 groups of drugs. Now let's talk about first group of drugs. It is NRTIs. So the first member, actually we consider zidovurin as the prototype. Then we have stovurin, abacavir, tenofovir, didanosine, salcitabine, and different doses are given. It is all these drugs are given orally, okay, except few newer drugs. All HIV or anti-HIV or antiretroviral medications are given orally. And some side effects, zidovurin associated with the myopathy, lactic acidosis, anemia and neutropenia, whereas stovurin, peripheral neuropathy, pancreatitis, lipoatrophy, facial wasting. Okay, so these are the common adverse effects, and you have to take care, because most of these drugs, all these drugs are inevitable part of all regime, unless the patient cannot tolerate or the virus shows significant resistance. Otherwise, these drugs are inevitable part of the combination regime. So metabolism part is also given here. Urine in case of zidovurin, whereas abacavir undergoes some hepatic metabolism. Then one more interesting fact is abacavir may be metabolized by alcohol dehydrogenase enzyme. This is actually an enzyme responsible for the conversion of alcohol, that is your ethanol, into acetaldehyde. Now let's talk about the mechanism. I told you these are the analogs of nucleosides like thymidine, cytosine, adenine, guanine, etc. And in the cell, inside the cell, what happened? The inactive form of azidovurin or zidovurin get triphosphorylated, not just monophosphate, diphosphate, and triphosphorylated. Now this triphosphorylated zidovurin is the active form. You can call it as a prodrug, and inside the cell it get converted into triphosphorylated zidovurin. I'm just quoting zidovurin as an example, and it can be active, and it can compete with the nucleoside and inhibit the reverse transcriptase enzyme. Only tenofovir, which does not require the triphosphorylation process, and it is active by the diphosphorylated stage itself. Rest of all the drugs require to be converted into monophosphate, then diphosphate, and finally to triphosphate. But tenofovir need not to be converted into triphosphorylated form. It is sufficiently active when it is diphosphorylated. After incorporation of so here this incorporation leads to termination of the DNA synthesis. Now what are the toxicities of the NRTAs? That's also very important. Lactic acidosis. Lactate level can be goes up. Shortness of breaths, if untreated, leads to death. So lactic acidosis is an important problem. Can you just tell me any other drugs which is not available, which was withdrawn due to lactic acidosis? Oral hypoglycemic agent. Just think about it and comment the answer in the comment box at the end. Hepatomegaly with steatosis is also another problem. Anemia, granulocytopenia, myopathy, these all are observed mainly because though it is specific to reverse transcriptase enzyme, it can sometimes it can also interact with the DNA polymerase, the inhibition of DNA polymerase, that is your human DNA polymerase sometimes, the non-specific action. Now the second group of drugs are non-nucleoside reverse transcriptase inhibitors. It is actually you don't have to remember about the ACUTE site. It is a P66 subunit of the reverse transcriptase enzyme. And what I want to tell you, this is not a structural analogs, but it is an enzyme inhibitor. Just inhibit the enzyme by blocking some or inactivating the enzyme. So this binding pocket, actually where the NNRTAs bind, there is a pocket, and this pocket is essential for the function of the enzyme to inhibit transcription, but it make a conformation change and inactivate the enzyme. Now the difference between one important, it is not structural analog, I already told you. Another one, in case of NRTAs, we need to be triphosphorylated, and NNRTA does not record any phosphorylation process. And we have delaviridine, nevirapine and efavirenz. Nevirapine and efavirenz. Delaviridine, nevirapine and efavirenz. These are the major three compounds. The pharmacokinetic features are given. I'll share the slides and you can compare. There is one more drug. It is etravirin. It's available elsewhere, not in India. I'm not sure whether it is. I didn't check the latest updates whether it is available now, but it was not available till 2018-19. Nearly 50% of the patients report some CNS psychiatric issues, and maybe some people discontinue due to psychiatric issues, especially efavirenz. Rashes, hepatitis with nevirapine is also noted. The third group is protease inhibitors. I think I'll do one thing. I'll divide the class into two. We will wind up here and continue the class as a separate next session. So I hope you could follow, and if you have any doubt, you can write in the comment box, or even you can directly ask me. I'm available on my phone. So please make sure that you are following the classes, and if you have any doubt, you can always ask me. Thank you. Thank you for your patience. We'll continue after some the remaining portion will be continued as a separate session. Thank you.